Hi, my name is Kevin Gonzalez, and I was assigned to do CT cystogram for this project. Initially, I had trouble researching a case study to use because I found out that Virginia Mason Medical Center rarely does this procedure. And I feel like most hospital does not do them often either, in exception to most trauma centers. But I'm not really sure, so if you could let me know if your site does this exam frequently, that would be great. Okay, so let's explain what CT cystogram is. Traditionally, conventional cystography was done to evaluate the bladder. Conventional cystography is used to diagnose and evaluate bladder rupture, leaks, fistula, post-op surgery, and traumatic injury. It is considered the standard study reference for evaluating these bladder diseases. Conventional cystogram or other pelvic studies uses antegrade bladder distension via IV contrast or oral contrast, and this usually takes a lot of time to fill the bladder. So initial attempts to diagnose bladder trauma with CT and IV contrast administration showed decreased sensitivity compared with conventional cystography. This was due to inadequate antegrade bladder filling from renal excretion. They also tried delayed imaging, which allowed further bladder distension. However, this also resulted in increased scan times, which is critical for multi-trauma patients. So CT cystogram was dedicated. It was a study that we use CT, but a retrograde bladder distension was utilized instead of IV infusion. CT cystogram created a faster, more convenient, and efficient way to evaluate the bladder in traumatic situations. It has then replaced conventional studies for traumatic injuries to the bladder. And axial images, MPR, and volume rendering is of course also a very helpful tool of a CT cystogram for bladder injuries. And since we are able to fill the bladder quickly, a CT cystogram protocol is imaging the bladder in pre-distension, maximum distension, and also post-void image was used. As I mentioned before, a retrograde distension is required, and we will achieve this via a Foley catheter under gravity control. A Foley catheter must be placed by a urology nurse or a CT technologist depending on your hospital protocols. In Virginia Mason Medical Center, they use Omnipaque 350 or Omnipaque 370 mixed with saline. It is imperative to have adequate bladder distension to eliminate misdiagnosis. If bladder is not filled enough, leaks, extravasation, and perforation can be easily missed. And the below image is an example of a fully distended bladder. Indications to use CT cystogram study include leaks, fistula, and diverticulitis, and tumors. And because ureters and urethra is also visualized and evaluated, urinary reflex and incontinence due to blockage or other causes can be evaluated using CT cystogram. Possible contraindications include pregnancy, contrast allergy, or UTIs. CT cystogram is best in evaluating in bladder trauma, of course, but it can also be used in diagnosing neoplastic diseases. Unfortunately, I couldn't find a trauma patient in our PAC system when searching for this patient, but luckily I found an interesting case combing through our PACs. This is involving an 87-year-old male with recurrent urothelial carcinoma. The exam reason is to rule out mets from his recurrent carcinoma. He had a history of bladder cancer, and they replaced his bladder with a neobladder. They used part of his small intestine, the ileum specifically, as a conduit. He also had left nephroureterectomy and prostatectomy and right urethral implantation. He has no known allergies in contrast, or and he had previous abdomen and pelvis CT. I don't think his previous abdomen and pelvis CT was related to his current disease. Pre-exam, he had urology order for a 14 French catheter urethral insertion in the urology department before coming into CT. I do think an MRI urogram would not be appropriate for this study because the patient would have to drink a lot of water to distend the bladder, and that would take a lot of time to fill. Also, IV contrast must be used as well. Additional to the longer exam times of an MRI, a full bladder would not be very comfortable for the patient. Fluoroscopy might be used for this case as well. However, we would not have axial images or MPR and other reconstructions available for evaluation. The technique and parameters listed is I found this on the CT department in our hospital website. Multi-detector helical CT is used. No IV contrast. The first images taken was an image of the pelvis without contrast. Then the bladder is filled with 250 cc of dilute Omnipaque 350, and it was instilled into the bladder under gravity control. Repeat axial image of the pelvis. This time, it would be imaged at maximum distension of the bladder, and also post drainage of the bladder has been taken. Sagittal and coronal reconstructions were used, and Radicat oral contrast was also used for this exam. Large scan field of view from iliac crest to below ischial tuberosities. High technique was used. KVP is 120. For our non-contrast images, the mass of 140 was used, and 150, 200 to 440 mass was used for our contrast with ASIR image. The two images below are examples of the coronal or sagittal images of a CT cystogram. The findings for our patient is no calculi identified in the neobladder or the right ureter non-contrast images, no filling defects in the neobladder, no contrast extravasation to suggest leak or fistula involving the neobladder, no adenopathy or abnormal soft tissue mass is seen in the pelvis. Also, no ascites and fluid collection. The contrast refluxes into the right ureter with no filling defects to suggest urothelial neoplasm. Basically, the impression is unremarkable CT cystogram, status post-surgery. No visible tumor identified in the pelvis in this patient with known recurrent urothelial carcinoma at the level of the urethra. Since the patient is dealing with his recurring invasive carcinoma within the distal ureter, his primary physician gave him three options. The first option would be a conservative approach wherein no approach to definitive therapy would be undertaken. And they would, at stages, plan to solve issues of obstruction to the urinary system either from the distal ureter or from the urethra. The second option would be a middle ground option, wherein they would utilize chemotherapy and radiotherapy. However, the ability to treat this disease would be limited on the basis of his chronic renal insufficiency. And lastly, the third option is a major option of extirpative surgery requiring radical neocystectomy, together with creation of ileal neobladder and concurrent urethrectomy. This is a large operation and certainly a formidable undertaking in a 82-year-old man. However, the risk and the benefits of each option were discussed by the doctor and the patient. At the end, the patient decided to go under surgery and pick the third option. Follow up his after his surgery, urethrectomy, resection of neobladder and rectal ureter, and a creation of ileal conduit. 10 days post-op, the patient was recuperating very well, and no other imaging was ordered for this patient. The lessons I learned doing this project is that many diseases can be diagnosed by CT cystogram, especially to bladder injury or pelvic injury. It is a fast and a convenient way for multi-trauma patients, and it can be easily done in a trauma center. Also, reconstructions are essential for trauma injuries. And that's it. Hope you like my presentation. Thank you.